Good morning, everyone. Thank you for joining online for this practical session in shockwave therapy. We hope you are doing okay in the UK. We are all positive and excited with this practical session. And we are welcoming today our shockwave expert, Daniel Morgan. Daniel, hi. Thank you for joining.
Hi. I've got Chris with me as well. As you can see, Chris is, it's not Chris Doughton, who is obviously part with the sales, but we've got another Chris who's in, who is kindly volunteered to be patient today, which is quite nice. So
thank you for joining, Chris. Thank you for being here.
Please say thank you.
So hi, everyone. Thank you for being with us today. So this session in shockwave therapy will be dedicated to upper limb areas. So just a quick introduction for those who do not know me yet. My name is Mary-Christine Colette. I'm responsible for all educational activities connected with the Swiss DolorClast Academy. What is the Swiss DolorClast Academy, known as the SDCA as well. So the SDCA offers shockwave training programs worldwide and trains the shockwave experts of tomorrow. And we have a big network of shockwave experts worldwide, including Daniel Morgan in the UK as an example. To help us support and spread out the word about the Swiss DolorClast method. So just before starting this webinar, as you can see on your screen, you have a Q&A and chat icons at the bottom or the top of your screen. Please feel free to use them and ask your questions, and we'll be answering them during the course of the webinar. So Daniel, off you go. I give you the mic to introduce yourself and start this webinar.
Bro, thank you. No, obviously, if you've seen any of the other webinars, I don't want to kind of bore you too much about myself, but I've worked with shockwave for a number of years now, 4 or 5 years, and I've been lecturing for a couple of years with EMS, and that's been superb. So what we're going to do today basically is we're going to run over all of the practical implements and some of the things that you need to consider when looking at shockwave for the upper limb. All the contraindications remain the same in terms of things to look out for with patients. So if they're on blood thinners, just be a little bit aware of those, bruising, excess bruising, all of that kind of things. Corticosteroids, as me and MC have just briefly discussed, if they've had a steroid injection within the last 6 weeks or 8 weeks, if it's the lower limb, we stay away from shockwave therapy just in general for that time frame. The reason being is that we suspect that with corticosteroid, that because the area is numb, the patient which means that they can put more load, that it's more likely to potentially rupture at that point. So that's the reason why we stay away from shockwave in those patients. MC, was the sound okay there? Because I was just thinking, I just had a notification saying my internet was unstable, but that was all okay?
There was a short cut, but it was fine. It was fine. We heard your sentence, so that was okay. I'll let you know if we lose you during
Thank
the webinar.
Thank you. Yeah, so that's the main concern with corticosteroids. But otherwise, I'll get into specifics regarding the condition as we go through them. So if we're happy, we can crack on with the actual practical. Happy to do so? Lovely. Right,
Let's go. Let's go for it.
Let's go.
Everyone's ready for it.
You are just sit face in. So we'll do the shoulder down. We'll work literally here down, which means that the first thing we're going to look at is either a adhesive capsulitis, or we're going to look at your supraspin calcific tendinopathy. So we'll do those. They are different in their techniques. So we'll do, again, you can do these lay-in and or sit-in. I tend to do mine sit-in, but some patients may be a little bit more comfortable lay-in. The reason why I do it sit-in is that some people tend not to be as comfortable when they lay down, particularly if they've got a lot of shoulder pain. And we need to fight against gravity as well. So you can do it sit-in, you can do it lay-in. It depends on the patient, but the place that you're going to essentially put the hand piece is going to be exactly the same, and the angles will be exactly the same. So have a sit for me, Chris. What we're going to do, we're going to try and get these angles of the camera right. So if I can wheel this around, means we can do the right shoulder. Okay, so for your adhesive capsulitis, you're going to be basically looking at 3 areas that you want to target. One of the things that we know, and one of the most sensitive tests that we can perform for adhesive capsulitis, is generally a palpation test into the coracoid process, or into the crackohumeral ligament. And it's generally identified in the research as being quite specific and quite sensitive. Now, generally, that is quite tender in a lot of patients anyway. But what we find is obviously you're going to get that restricted shoulder flexion and restriction in external rotation. So we will still provide, you need to make sure you can get that diagnosis correct, really, for this. When we look at it on ultrasound, there is some chance that you will see some increased vascularity, some blood flow around the, basically around the bicep tendon, because you get thickening of the crackohumeral ligament. However, it is also possible to have a confirmed diagnosis of frozen shoulder or adhesive capsulitis with no signs of ultrasound. So ultrasound is a little bit hit or miss with the confirmation of a diagnosis with this one. But for the sake of just your physical and manual testing, a simple palpation test into the crackohumeral ligament will suffice and will be quite sensitive and specific. So now that we've done that, the first target is actually the crackohumeral ligament. And what we generally do, we have the patient to sit and we get them into external rotation. And what that does, we can then put a little bit of stretch right into there. So what we do is just 1,000 impulses into each area. Again, go in to the patient's tolerance with this. Now, Chris has got pretty good external rotation. He obviously hasn't got a frozen shoulder, and it's probably not the correct demographic, but what you will find is that a lot of patients will be struggling to get to around about here. Now, what we can do is we pop obviously the contact medium in. I'm going to go again really light with these pressures for Chris, because like I said, he hasn't got the pathology, and there's absolutely no need really for us to be doing it other than just the demonstration purposes. So your coracoid process is in here, and we are going into there. Now, I tend to use between 8 and 12 hertz for this. However, if the patients are struggling, then you can obviously increase that frequency, or you can decrease the pressures. Rule of thumb is always use the pressures to the patient's tolerance. But what we are showing consistently in the literature is the higher levels of energy that can be provided into the tissue, the better outcomes that we are getting. Now, that doesn't mean be brutal, but it does mean just try and push that tolerance a little bit. If we use a rule of thumb of 7 or 8 out of 10, okay? So again, I'm going to go a little bit lower because, like I said, there is absolutely no reason for Chris to be here. So we're going to go 1.5, and we're just going to go in, and we're going to angle directly backwards. Now, if we angle in, we've got our lung, and we don't want to be doing that because then we can obviously risk a pneumothorax. So anything over the lung fields is a little bit sketchy, but for this one, we're going to come in, coracoid process, and straight into there. Treatment is not active. That will help, wouldn't it? There you go. Ready. And I got ready again. There we go. So we're just making sure we can go round in a lovely circular motion, angling out. We can angle left to right, medial to lateral, superior, inferior. So what I'm aware of there, I might have covered where the actual applicator was being triggered for the majority of that. However, I'll do it again just by, so I put another 500 in there for Chris, just because I don't want to put him through unnecessary pain here. But out of interest, where can you feel that? Is that coming through to the back of the shoulder, or is it just in the front?
Slightly to the back,
so
down the front of the...
Yeah, so it's coming with Chris, it's coming into the back as well a little bit, which is what we're after with the frozen shoulder stuff. We're aiming directly through the glenohumeral joint a little bit. Obviously, we're seeing some capsular adhesions within that, and that mechanotransduction is going to be really beneficial for the treatment. So we're going to just come into there. Again, they're angling really laterally, and we can go around in circles there. No, I will. Okay, so it's that area, and we're just moving this in a circular motion, up, down, side, side. Now, not too much, obviously, come in there. We don't want to be in here, but we're just trying to little bits of circular motions and patterns in there. Okay. Now, same position for the second part. I'm gonna just get, Chris is going to be full of this gel later. So we're gonna put the second part on for the pec insertion. And one of the things that is quite deceiving with the pec insertion is a lot of people assume that it's coming up into here, but the pec actually plays a stabilizing role in the biceps tendon. So the pec actually comes around about this level. And that's a little bit uncomfortable there. So the pec will stabilize that bicep, and it actually stops the bicep from coming out of its groove a little bit, along with other ligaments that we get going across there, the transverse ligaments, etc. But this plays a role in just getting that external rotation a little bit better. So same again, 1,000 impulses into that area. So Chris is going to go external rotation, and we're going to do exactly the same here. So it's just going to come across. We're working through into that pair. Okay. So again, we do 1,000 impulses. I've just done probably 300, I think. But we do 1,000 there, and then so we got 1,000 here and 1,000 here. And the next one is the posterior element of it. And what we're going to do, I'm going to steal some and pop it on the back. I may actually, yeah, if you can, just turn slightly. Lovely. We've done this before. So with this one, again, we're aiming directly to that joint angle. Now, we have to be a little bit careful here, because if we are going too medial, we're probably going to be a little bit in lung region. However, we have got your scapula. So the scapula will protect this posterior element, and we know shockwaves will not travel through bone. So that's fine. So just try and relax it a little bit. That's it. So now we're aiming right at the posterior capsule, and we're just going to come in, and we're going to go, I need to put another couple of 1,000 on here. There you go. So again, 1,000 impulses, and we're just going to go straight in. Going into the front. Put a little bit more energy in there. That probably will. So at the moment, I'm on 1.5 bar. So this is the lowest that the master touch will go. Now, if I start to I'm just going to show this for demonstration purposes, really. Chris is all right with it. We're going to just
Anya?
put a little. Hello. Yep.
Yeah, you are using the 15 millimeter applicator, right?
Correct. Yes.
Okay. Okay. Thank you.
No problem. So we just aim in directly in. You feel that a little bit more. So now we've gone up to the energy levels. We've gone up to around about 2.5 bar, which means that we're probably getting around about 2.5 centimeters of depth. So that's why now Chris is getting a little bit more into the anterior element of the shoulder. So those are the 3 key points that you want to be using your adhesive capsulitis protocol. We're going up into the higher levels of energies that we can get and that the patient can tolerate, but those are the 3 locations. So really nice, really easy. What you can do as well is that you can maybe use the 36 millimeter head and you can run over into the super spin and even down, because what we know is that the fascial connections will come down into the arm. So you can potentially work down the biceps and into the distal biceps tendinopathy with the larger head if you really wanted. So you can do just 1,000 impulses and working down into this fascial chain. So I can show you that, provided that I can change the head. I've got 2 of them in here. Okay. So I'm going to just change the head. When you change in, by the way, I'll show you this. When you change in the applicators, we have to be just a little bit wary that they are full of seals. Now, if you change them that way and you take it off, there's a chance the seal may fall out. You put it back on and it will lose pressure. So just be a little bit aware that take them off facing down, because that is just safer. Mainly for the machine maintenance, but nothing to do with performance or anything. Or you haven't got to do it, but it's best practice really. So we're just going to, and simple, obviously screw the applicator back on there. Now, this isn't an essential part of your treatment for adhesive capsulitis, but we will also kind of do the same thing for calcific tendinopathy as well. So this will hold true for calcific tendinopathy as well, that you can use a larger head. Again, we've got to be quite careful with this, but if we go back to our theory, we are using probably 4 times larger surface area here with a 36 millimeter head, which means that approximately you're getting less than half of the energy that is being delivered through this applicator head. But this is still quite nice for hyperstimulation and things like that. So I tend to use 1,000 impulses, 15 hertz. So I'm going to pop that up a little bit on its frequency and just put 1,000 impulses there. And what I've done differently is obviously if you're working quite the way down the chain here, you're going to get a lot of, it's a long chain to put down the contact gel. So what I've done is I've actually just put the contact gel onto there, and now I can start to rub it down, which means that you're saving yourself on the contact gel a little bit. Now, with this, again, we've got to make sure we're angling down and we're right onto that supraspinatus, because otherwise if we're over here and we're going into the lung field, so you just got to be careful with that. So we just come in there, work down the bicep. You're done. So there's 1,000 inputs. So that's typically, and I don't know whether or not Chris will feel a drastic benefit to this because he didn't actually have a great deal wrong with his external rotation. But just have a little move of that, just see if I feel like looser. And he feels like it's going further as well, so that's a good sign. But even though he didn't actually have a great deal wrong with it. So this is quite a nice little additional extra that you can give to the patient at the end of the shockwave. It's more of a fascial release down that chain for the adhesive capsulitis and for your supraspin calcific tendinopathy. Speaking of, we'll move on to that one. We'll move on to your calcific tendinopathy now with the supraspinatus, which is the most common calcium deposition site. Now, there are other areas that you can frequently get them into the infraspin, the subscap, etc., and you can see those on ultrasound scans quite well. However, what we do with this is just to bring the supraspin a little bit more forward. We bring the patient's arm around the back. So now your supraspinatus muscle is here. And anatomy-wise, it'll come all the way under, obviously under this, the subacromial space, and then it'll attach quite broadly here. Now, is that quite tender? Sorry, that's all right. Chris hasn't got a problem with his shoulder, so we're okay. But it's going to be just right into that location. And what we find is that the calcium site can vary. They can vary in solidity, they can vary in size. So if we've got a large calcium deposition, what the literature is saying, what is obviously important to know is when to treat, but when not to treat, and when to maybe expect lesser outcomes. And when we're talking about lesser outcomes in this case, we're talking about calcium reabsorption. So what the literature is actually saying is that if we have a calcium deposit that is larger than 1.5 centimeters and has been there for longer than 11 months, we're less likely to get full absorption of that calcium back into the tendon and back into the bloodstream. So that's one thing for you to consider, is based on the size of that calcific density, don't overemphasize the reabsorb, because that's not necessarily going to happen. People will sometimes expect to see changes on ultrasound, and again, within a certain period of time, you're going to get a reabsorption of that calcium anyway. But when it's been a chronic, longer than 11 months, and it's larger than 1.5 centimeters, less than 10% of patients get full reabsorption. So it's key for you guys to actually be aware of the size of the calcium deposition, how long it's been there, etc. So just bear that in mind when you are using this. But that doesn't mean that we can't improve the patient's function and pain relief for this process. So just bear that in mind. But what I want you to kind of get from it is know what to tell the patients and know what they should expect from the treatment. Because if we continually put emphasis on you will get reabsorption and that calcium level needs to drop, sometimes you don't see that, but you will see reduces in pain, etc. Right, so just bear that in mind.
Dan, we had a couple of questions. A question from Chris Danton.
Yeah.
Do you perform the standard 3 treatments, or does it depend on how chronic the indication is?
Good question, Chris. So yeah, typically I will do once a week for 3 weeks. Then we do a review at 4 weeks, and then we decide whether or not that patient requires another 3 sessions. Now, again, this is NHS guidelines and NHS standards. So EMS were the ones that provided that information and those protocols to the NHS, and they followed those guidelines. Now, the key thing with it is that there's no maximum amount of sessions that you can deliver for shockwave therapy. And again, that will depend on chronicity, etc. But there is a minimum. So the minimum is saying we should always do a minimum of 3 sessions, but there's no maximum allowed for how many we can and cannot do. Now, that basically comes down to ethics and your clinical judgment. Now, for me, my rule is that if a patient hasn't responded and has 0 response within 3 sessions, they're unlikely to have a greater response in the following 3. However, that doesn't mean and I mean, when we say no response, I mean 0 response, like not just like, oh, 10% better, 20% better. If there is no change, this is unlikely to carry on. Well, I'm unlikely to carry on and do the other 3. However, there's no reason why you can't, because like we said, protocols do suggest that actually in the second, third, the second batch of 3, you do get better outcomes. So don't panic if you're not really seeing, 80% recovery within the first 3 sessions. But if you are getting maybe a little bit, 10%, 20%, by all means, crack on and do another 3 sessions. Again, you can do another 3 and another 3, but that comes down to financial implications for the patient and your ethics really as to whether or not, and your clinical judgment as to whether or not you feel as though it's going to be more beneficial for them. So there's no maximum number of shockwave sessions that you can, but I tend to do 4 maybe as well on certain occasions, certainly for hamstring tendinopathy. And even in the literature, hamstring tendinopathy is saying that you need 4 sessions. So there's that. So it does depend very much on location, chronicity. That all plays a role on how many sessions you may need to get maximum recovery. Interestingly, while we're talking on the upper limb, but Chris has actually been one of my patients for hamstring tendinopathy, so and done very, very well. So that's a little positive there.
That was a good question.
Any other questions there, MC? Yeah, there was.
Yeah, we have a question from Heidi, who would like to know if you ever treated patients who feel nausea when you work shockwave on the subscapular.
I haven't, but we did some work yesterday, and the patient did feel a little bit like lightheaded, I think, and that's predominantly due to what we class as like a vasovagal response, which is just that the pain is a little bit high, so they tend to shut off.
Due to discomfort, then.
Basically, yeah. So it's just the pain levels and their pain tolerances, but it's not necessarily it's not a direct response. Well, it is a direct response to shockwave, but it's not as though you're doing anything damaging. It's just that they probably don't like it, so they want to shut down, and that's why they might get a little bit lightheaded and a bit of nausea.
Okay, thank you. We have 2 other questions from Andreas. Andreas, good morning. Andreas from the Netherlands. It was asking, when you started treating the shoulder, so he said, why the anterior method? I assume the subscapular muscle. Is treatment from the axillary region not more effective?
We're not treating the subscap, we're treating the craccohumeral ligament with this one. So you're right, if you want to go into subscap, yeah, but we're actually demonstrating onto the craccohumeral for this, because that is the site that gets thickened. So yeah, absolutely spot on, but we're not aiming for the subscap during adhesive capsulitis.
Okay, perfect. Thank you. And the second question from Andreas, who would like you to explain on which theoretical construct your treatment is based upon. Are you aiming on pain substance P or the release of lubricin? Or can you combine shockwave treatment with passive mobilization manual therapy?
Yeah, absolutely. There's no reason why you can't. So what we find with adhesive capsulitis, which is obviously what we've just run through, is that you will get immediate pain relief, you will get immediate changes in function, and then what you can do, certainly what I do, is I'll get a little bit of thoracic mobilization and thoracic manipulation in there as well, because that will play a massive role. So there's no reason why you can't combine it, and I do, so there's no reason why you can't. And you can, what you will find is that sometimes if you're doing a little bit of mobilization, etc., it can be a little bit uncomfortable afterwards. It's just how much you want to push the patient and how much they can tolerate. But there's absolutely no reason why you can't combine treatments in any way, shape, or form.
Thank you.
That's okay.
So, no other questions. We can continue.
Perfect. We will continue. All right. do you want to do the other shoulder, Chris, just because it's, yeah, we keep it that one. There we are. So pop your right arm around the left me. There we go. Right, so with this, let me get Chris's shoulder in. There we go. So super spin, as we discussed, is coming around into here. Oh, there it is. So we're gonna, yeah, you should feel fine after this. Chris has got a little bit of DOMS, he's just announced, and he may be a little bit tender, but that's fine. So again, I'm going to just put the 15mm applicator head on, just so I can change this over. I'm doing this a little bit wrong-handed at this point now, but we'll be absolutely fine. I'm going to drop this down because, again, 2000. If I can. 12. 15. Okay. So with this one, we can apply 2,500 impulses. Uh-oh. Are we back, MC? Did I cut out a little bit then? Or am I okay? Cool. I don't know. We back, MC?
Yes, back.
Yep, okay, good.
I'm just reading the comments. We have a couple of comments, so but just
fine.
Go and treat, and then
just
we
continue.
ask
Okay,
questions.
no problem. Right, now I am really wrong-handed for the camera here, but I'm gonna go around the other side here. No, you're good. So with this, I tend to do exactly as I was, and I tend to use a lovely little pencil grip because I feel like I've got more control. So I'm doing this left-handed, so don't judge me with this one, okay? But we're gonna be just there. Now, this is gonna be right into that super spin. So yeah, I'm on the lower setting, I'm on 1.5 bar, and I'm going up to 2,500 impulses at 12 hertz. Now, obviously, again, I wouldn't, if I was looking for a therapeutic outcome here, I'd be looking at maybe 2.8 up into 3 bar, maybe higher. Depends on what Chris can tolerate and what the patient can tolerate with the calcific density. Like I said, what we are consistently finding is if the patients are able to tolerate higher energies, then they will get better outcomes. So just bear that in mind. Okay, so all it is a simple making sure you're coming right into that anterior margin of the greatest tuberosity. And we can come up and down and angle through. We would continue that just for the 2,500 impulses. And what we would then do is we would go into the super spin muscle itself. So I tend to work just a little bit over here and looking directly over exactly where we were, but I'm keeping the 15mm head. So 1,000 impulses, 15 hertz, and then running through. So again, be sure to angle down, not over. So you got your apex of your lung here. I knew it. That one's it's a little bit of a trigger point right there. You can work just right through onto that trigger point. You go from there. Okay, so 1,000 impulses into that super spin, and then you can do your fascial release down and into the distal bicep as well. Basically, that doesn't change for your subacromial pain. That doesn't change for your supraspin tendinopathy. It's really the same because it's the same tendon that it's involved. So you can, as well, exactly as was mentioned, we can go under, actually, under into the axilla for this subscap. I don't tend to do a great deal of this. I actually put a little bit more emphasis on to scapular kind of stabilization stuff. So, and maybe a bit of neuromuscular re-education in terms of just retraining the actual movement patterns that we would see. Because usually what we also find is that it's very rare we get a physical impingement. And what I mean by physical impingement is that the tendon literally will not go under that subacromial space. Normally we will see tendinopathies and we will see calcific tendinopathies, but it's very rare we see a physical impingement. But obviously the function is still altered with these conditions as a result of pain, and is trying to adapt. So there's no reason why you can't work under into the subscap, which you can have the patient lie in, and then that exposes that subscap and you can go into there. There's no reason why we can't do that. I don't do a great deal of it, but there's no reason why you can't. It doesn't mean that it's wrong. As you said, you know, if you can find trigger points in there, you can work them. For trigger point work, what I do tend to do is around about 2.8 bar, 12 hertz or 12 to 15 hertz, and we'll do around about 500 impulses into each of them. So there's no reason why we can't. I'm just going to quickly wash my hands. So yeah, that's really the two shoulder conditions there that we're getting the best benefit. When we discuss calcific tendinopathy versus just a simple tendinopathy, or subacromial pain syndrome or subacromial impingement, what we know is that there is significantly better outcomes in the literature for calcific tendinopathy versus your non-calcific tendinopathy. So it just means that you're getting better scores in the literature, or better outcomes in the literature for a calcified tendon versus a non-calcified tendon. Just bear that in mind as well. Do you want to go on to the elbow, MC?
Yeah, maybe just a couple of questions to answer. We have a question from an orthopedic surgeon who says hi to you, Jay Jayabalan, who's asking what are the contraindications for this procedure? I mean, for shoulder shockwave treatment, metal implants, age. What are the complications you have seen? How long have you been using such treatment?
Right, okay, there's a lot there. So we've been using the treatment for shockwave and calcific tendinopathy for years. It's safe, it's effective. With regards to contraindications, the contraindications are the same for all shockwave. There is maybe extra considerations to be made here for pacemakers, because again, what we tend to say here is have a discussion with the cardiologist. Some cardiologists will say, yeah, you know what, you're absolutely fine. You can treat. Others will say, absolutely not, it's a complete contraindication. So what we tend to advise you is to raise that discussion with the cardiologist first, and if they are happy for you to proceed, then you feel free and you do so. If they're not, then obviously, you know, you don't, basically. With regards to metal work, it depends what type of metal work we're discussing. There's obviously a little bit, if there's been repairs, etc. We know that if there's a tendon rupture, that is a contraindication anyway, or a previous tendon rupture, that's a contraindication anyway. So it depends on what metal work we're talking. If we're talking replacement surgery, you know, we say there's extra precaution that needs to be taken place here with shoulder replacement. Obviously, what we need to establish is why that shoulder is in pain before you do treatment. Has the shoulder replacement taken? Has it been dislodged in any way? Or is it just simply, you know, capsular tightness and just adhesions really in the surrounding musculature? So we're okay, like when we speak to our, you know, orthopedic surgeons that work with us, they say if the replacement has been in place for 6 months, then it should be absolutely fine. That's providing that it depends on what your goals and what you're trying to achieve really within that sessions. I don't know if there was anything else to that question. Safety, was that it? I think, I don't know if there was multiple points to it.
There were metal implants. How long have you been using such treatment? I think, complications. I think you answered everything.
Yep, got it all. Good.
I think it's fine. We had another question from Michelle for AH. Using a 15mm head, 1000 shocks, which frequency was used? Is it based on patient tolerance? Yes,
always based on patient tolerance. I tend to use 12 hertz, 10 to 12 hertz as my, obviously I've got the Master Touch as opposed to the Smart 20, which means that you can have a little bit more of a personal effect with it. So I tend to use between 10 and 12. And even then for the trigger point and myofascial stuff, I go up into 15 to 20.
Okay, perfect. Thanks. We have a question from Gail Maffley, who's saying, excellent presentation. Thanks for Dan. With regards to PPE, do we not need to cover the probe with protection?
I clean it. I completely clean all of mine. So I've got antiviral wipes, etc. There is a school of thought as to whether or not you should be wearing visors and glasses, etc. It's not essential for us in practice at the moment to be wearing them. It is one of those ones that basically, we've got our aprons on, we've got our scrubs on, we've got our gloves on. It is an extra consideration to be certainly covering the head, applicator head if you needed to. It does save you with cleaning, and also visors is the other thing that we potentially would advise, only because sometimes you do get a little bit of splashback from the gel. So it's non-essential, but it probably is best practice. But what I find is that when I'm wearing my glasses, they steam up and I can't see. But that's obviously something that you can kind of work around.
Perfect, thank you.
Yeah, thanks,
another question from Chris. For shoulder treatments you have shown, do you have a specific pre-shockwave treatment assessment you could show us?
Oh, thanks, Chris. Yeah, so what we tend to do is obviously confirming a diagnosis, etc. So super spin is relatively easy in terms of what we would look at and how we would assess it. So the first thing that we always do is look at the range of motion. So I'll run through that with Chris now. So we're going to look at the range of motion of the patient. So we can do this both active and passive. So we're going to bring this up into shoulder flexion, so we can do it passively. And Chris has got exceptionally good range of motion there. And we're going to bring it back into extension. And again, really good. You can measure that. Now, what we then do is go into abduction. Now, typically what you'll find is with these patients, they're going to pinch you. Now, an active form of this is something called painful arc exam. So you're just going to bring your arm out to the side there, both sides, do that, both sides, and then just slowly control over the top for me. Now, what you're looking for is any imbalances, and normally the patient will pinch at around about 90 degrees if there's any issues. Now, one thing that you need to do with all of the shoulder stuff is rule out any potential tears. So one of the things that we do to do that is something called drop arm test. We just bring the arm up. I'm going to just show this. So I'm going to go here. So I'm actually supporting the arm. And then I'll ask Chris to try and take the weight. And he isn't dropping. Now that is a sign that his rotator cuff structures are all intact because he's able to stabilize it. Now, in the instance that that's to drop and he can't do it, they may suggest that there's a rotator cuff tear. So that's one thing for you to consider. Now, if that is the case, maybe you should look at further investigations, looking at ultrasound scans or MRI, etc. However, just be aware that you can sometimes get some false positives with these if the patient's in pain. So if the patient's in pain, they might actually go, oh, because of the pain rather than the instability or the weakness. So clarify as to why we're in pain. Then we've got a couple of tests that I would typically do in clinic. So we have empty can or jobs, where we're just going to come into there and we're just going to have you to push down. So I'll push up into my hand. If there's any pain there, that may be a sign that there's any impingement or something going on within that super spin. Then we do Hawkins K exam, which we can come into there and bring around. Again, Chris's internal rotation is absolutely fine. I mean, it's 90 degrees, there's no issues there. And we can do it into the anterior position. And that is a little bit uncomfortable. Yeah, a little bit uncomfortable in the anterior. So even though Chris has got no pathology, that can still be a little bit uncomfortable, but we assess both in this position and this position. So with regards to assessments, we can then obviously, with the range of motion is quite important to assess, particularly with your super spin and your adhesive capsulitis patients, because that acts as a tool then that you can say, well, what can you do? Well, I couldn't really go back. Well, now you're going this far back. We use some functional things as well. So we'll use some questionnaires that the patients will run through. So we're looking at SPADI questionnaires, which is shoulder ADIs, basically, active daily stuff. They're looking at the function of the shoulder on questionnaires, so we can get a quantitative value of how that patient is improving throughout the course of the treatment. So they are quite useful little things that we would generally use.
Thank you.
Happy with that, Chris?
Thank you for this complete answer. Quick question from Sergio. Do you use any pain relief medication and ice after shockwave treatment? So
pain relief it depends on what you can use some pain relief. Now, not for the session, because interestingly, what we know is that if you do shockwave under anesthetic, for example, you get less favorable outcomes. So it almost stops and prevents that neurological cascade. So the substance P release and that kind of neurogenic inflammatory response, it sort of stops that cascade going on. So we get less favorable outcomes if the patient is having their treatment done under anesthetic, local anesthetic, or if they've got anti-inflammatories, etc. So we tend to stay away from it as much as we can and try to have more of I hate the word, but more of a natural kind of healing response.
Okay, thank you. We have a question from Sida Jayabalan. Saying that the presentation is great. Did you see any complication in the shoulder area?
To be fair,
she said you mentioned lung injury.
Yeah, that is the one risk. Like, we haven't seen them actually, not in private practice, but there is the one risk of obviously working over the lung field. If we work over the lung field, then basically when you look back to the history of shockwave therapy, shockwaves were discovered during World War I when people were coming in with pneumothorax and internal lung injuries, but without any external traumas. And that was from shockwaves, from explosions, etc. So that's how we know that it can be detrimental. Obviously, they're a lot higher energies than what we're delivering, but we know that it can be detrimental to air-filled regions, hence why we don't use it over the abdomen, why we don't use it over the lung field.
This is why the angle. This is why the angle of the handpiece is very important. Yeah.
Absolutely, yeah. Yeah, perfect. So yeah, I mean, realistically, I'm quite fortunate in the sense that we've got ultrasound in the clinic, which actually the laptop is resting on at the moment. But we've got ultrasound in the clinic, so we're able to establish whether or not the patient is suitable for it first. Well, not that they wouldn't be, but what we do is just get that extra confirmation of what we're treating, really. You can suspect it and you're able to treat off a clinical diagnosis, so there's no issues with that.
Thank you. And a last question before going to the elbow. Question from Jonathan. So going back to the frozen shoulder treatment, you mentioned 1,000 impulses. What scientific data exists for this choice? Why not 2,000 impulses? He's found that in frozen shoulder, the latissimi dorsi is short. He uses shockwave over the tender points in the latissimus to reduce spasm and increase ROM.
Yeah, so this protocol is based off the literature. I don't know the reference off the top of my head, but I can actually get that reference. This is actually based off that study, and that study was showing the best outcomes. So that's why we use that protocol. I can get that if need be, actually. Let me do that now. What for you? I'm just going to just Google it. I can't remember the actual reference that I'm looking for, but it is based on a particular study that we have and that we use for that. So that is why we use those settings. I've got them all on my file here. I can't remember I can certainly give you the reference. I'm on it now. Frozen shoulder. Well, the other thing with the frozen shoulder is actually one thing that you should be aware of is the diabetes. So we know with all diabetic patients that they have a slower response. So, and we also think that diabetics and diabetic frozen shoulder may be a slightly different pathology or pathological process. So just because when we do the hydrodistension, the people who have had a diabetic frozen shoulder tend to have less favorable outcomes. So just be aware of that one as well. Right, there it is. That is Hussein 2015 is the protocol that we use. Yeah, Hussein. That's why we do the 1,000.
Perfect. Thanks. We can go. Yeah, we can go ahead with the elbow.
Lovely. We can change. Well, you can put your top back on now, Chris, as well. What I'm going to do, I'm going to just change the setup slightly. Normally, we can do this on a chair or on the table, etc. What I'm going to do is I'm just going to pull this chair up and we're going to have the patient rest their elbow onto the bench. So it's just a little bit easier for viewing. But yeah. Plug you in. I'll sit on the chair for you then. Right, if you can, pull the chair up and you can just rest that elbow on. That's it, perfect. So, we're all done. Right, support, lateral. I'm gonna get my wheelie chair here. Oh no, I'll have a stand. Okay, so when we're looking at your frozen shoulder, when we're looking at your tennis elbows, we're looking at lateral epicondyle, okay? So what we're looking at really is if the patient can pull that finger up and there's no pain, then it's unlikely to, and the middle finger as well, and there's no pain, it's unlikely to be a tennis elbow. However, palpation is quite tender in there sometimes, and we can do, just make a fist for me. Bring it in, and I'm just going to pull down. That as well is just stressing that common extensor origin right into, there we go, right into that location. Okay, so what we'll see is that this would be quite tender. Now, what we know from the literature is, again, you get mixed results in the literature, and the ones that get poor outcomes tend to be with the patients that haven't really had a great deal of energy put into it. Now, it's really difficult because this is quite a superficial surface. However, you are being cruel to be kind with this. So if you can put a lot more energy into it, you will get better outcomes with it. Okay, so just bear that in mind. Very similar across the board, really. But with this one, it's quite simple. We get our, you're comfortable there. Do you want to raise it up a bit? So we're going to just pop the contact on. Again, yeah. And we're just going to come into that lateral epicondyle. Okay. Now, again, I would use 2,000, 2,500 impulses at around about 10 to 12 hertz. And I'm on the lower setting here, 1.5, but if you're looking at it between a therapeutic range, we really want to be up into the 2.8, 3 bar region. So just bear that in mind. So we're just going to go. Just again, going into that circular motion. I like that. Okay. That's not too bad for Chris. I'm on 1.5 bar. Now, what I will do, I'm just going to show kind of a level that we do need to be at. And I'm not going to do this. I'm not going to do this for too long for him because it is a little bit uncomfortable. But yeah. So if you can see Chris's face has changed a little bit. So we are using, that was 2.7, 2.8 bar, just getting up into that elbow. And that's kind of where we want to be focused really for the main pathology. When we're looking then at some of your fascial release stuff, we can use the same 15 mil head. You can use the 36 mil head. I tend to use the 15, but we can just run down the extensor musculature. So I've increased the frequencies to 15 hertz. I've got 1,000 impulses on, and we will run down the muscle belly. Okay. And one of the other things that often becomes affected with the tennis elbow is going to be your distal bicep. And its attachment is actually right onto the radial tuberosity, which is tender there a little bit. Yeah. So just contract that for me. There you go. So we can just feel that we're going to get a little bit of tenderness right into there. So because of its attachment onto the radial tuberosity, sometimes we can actually work over there. Now, there's no evidence to say that there's a detrimental effect when we work over arteries. However, it is a precaution. So if we're working over major arteries, there's no evidence and there's no like reported negative outcomes or negative incidents with working over the arteries, potentially because there hasn't, no one's going to get ethics to report that. However, we do just need to be a little bit careful. Obviously, the biceps artery does run directly over the biceps tendon, so just be aware of that as well. Like I said, there's no reported negative outcomes, but just on the safe side, just want to mention that. Yeah, Chris is fine. So what we're going to do, we're going to just pop that down there, 15 hertz again. Now, what you can sometimes do is you can come medially an angle. That's actually how we achieve a good image on ultrasound, is by coming medially. So that's one of the ways that you can, because ultimately sound waves will travel in the same direction. So just come in medially there and you can work through. So that's another nice way that you can try to get onto the distal biceps. And ultimately that's the same for distal bicep tendinopathy. So you get in, rather than just doing 1,000 impulses into there, you can do the full 2,000, 2,500, getting up into your more kind of therapeutic levels and building up into 2.5, 2.8 bar and beyond really. So that's quite a nice little technique. So so you can come in just into there and angle across. So that's quite a nice way. Or likewise, you could do that way. So that way. Okay. So you've got plenty of ways of doing this, but just be aware that you do have the arteries like directly superficial. And again, there's no negative outcomes in the literature, but it is one of those things that we say just as a precaution because we don't know, really. Now, golfer's elbow, we can just go there. And one thing that you have to be aware of with golfer's elbow is that there has been a reported of one reported outcome of ulnar nerve palsy, which I think was actually in South Korea. And in South Korea, they were arguing that they don't actually believe that that was shockwave that caused that anyway. They think that there was potentially a neuropathy that was going on at the same time. But we would obviously be negligent if we didn't inform you of that potential risk. Now, realistically, when we're looking at it, we're very unlikely. So I can just show you there, your ulnar nerve is going to be in that ulnar groove. Now, with the flexors, they're going to attach, let me wheel that around, there we go. They're going to attach into there. They're going to attach into here, your ulnar nerve is here. So if you stay onto the forearm element of it, around into the anterior aspects, you're not going to be anywhere near that ulnar nerve. So just make sure that we stay this side of the elbow really, which that will all change angles now as soon as we get that there. So we want to stay this side rather than coming around because that's where your ulnar nerve is going to be layering, or well, living. So we're going to, again, higher energies the better. Using your 2000 impulses, working into there. We've got a positive outcome actually with most of these. Even the literature is giving mixed results, but we've had some really, really good outcomes with this. We've had a patient who's come to see us who has had a bilateral, unbelievable really, but he had bilateral golfers and tennis elbow. And he was sent to us from a GP saying, try it, it might work. And otherwise he was due for tendon debridement on that area. And now he hasn't had the surgery and is completely asymptomatic on both elbows. So we had a really good outcome with that in clinic here. So just, you know, you can get really superb outcomes, and that was with 6 sessions. So can you see? I think you can. Yeah. Oh, there we are. Perfect. So again, we just common flexor origin is just going to be right up into there. And this is going to be very bony, this area. So we just try to, like I said, stay onto the superior element. I'm on the wrong frequency for you. We put that onto 12 hertz again. What you can do is you can actually just get a little bit of a stretch through the forearm. May help. Doesn't really matter, but you just aid in that mechanotransduction process through the tendon. You can do it without, but it's quite nice that you can, been angling off the edge of the bench, you can do that. Working in. And then again, you run down into the forearm.
On the forearm, you do 500 shots on the forearm? When you
can either do 500 or 1,000. There's no real, because again, we're working on fascial stuff here. That's not the end of the world. You can use the 36 mil if you wanted as well. I tend to use most of mine on the 15, but you can use the 36 just to be that little bit kinder and working more fascially and more superficially. So yeah, that really is the elbow. I think they're really kind of nice and easy, really nice and simple. But the upper limb, you can get some really, really good outcomes with it. Obviously, the literature has historically been lower limb for a number of years. Tennis elbow is quite widely investigated, actually. But plantar fascia and Achilles have got the abundance of literature and research, but we are trying to expand that now. So, yeah, it's all pretty good. If any questions that have arisen from those areas?
No questions. Everyone's quiet. We just have a comment from Heidi. Heidi saying, well, talking about carpal tunnel syndrome.
Yeah, so
she had last year. She had carpal tunnel syndrome surgery.
Yes.
And she used shockwave on the scar tissue after 8 weeks, and it worked pretty good. And good results.
That's superb. Yeah. Like, I tend not to use it for that, just because I know that it's not. It's a little bit more of an experimental kind of section, rather than, you know, an abundance of literature into that area. But I you know, if it worked for you guys, that's amazing. Carpal tunnel is a little bit. It can be quite painful and a little bit, you know. Yeah,
and you might use a low pressure and low frequency as well. Yeah, it's a bit. Yeah, it's a tricky area of the body.
We are actually having. We've got a patient in at the moment with Dupentrons, and we're getting some really decent results with Dupentrons. So, Dupentrons contracture within the hand. So that Dupentrons is a nice
tendinitis of Kervin, you mean?
No, so that would be like a de Quervain's. What we're looking at with Dupentrons is almost like a fibroma within the tendon, leading towards the fingers, and they start to kind of come down. And the patient came in like that, and after 2 sessions at the moment, she's almost up straight. So we're obviously got another session this week, and we're going to see how that's going. But she's doing really well. I know Johnny, obviously colleague as well in the UK, has had some decent results with that. So yeah, we you know, it does help with Dupentrons as well. But I mean, really, we're just working into the fibrous sites and going through there. So it's quite good. But that's really it from the shoulder and the elbow.
Well, yes, I guess we don't have any other comments. I have a question concerning the elbow treatment. Do you get successful treatments on, well, equivalent results, successful results in terms of golfer's elbow and tennis elbow? Same results? Or do you have any recalcitrant situation where you have to combine other treatments to have a fulfilled treatment?
I always use shockwave as a standalone. So I will always use shockwave therapy as a standalone, and I actually seem to do pretty well with golfers and tennis elbow. It's possibly because I'm not frightened of really putting in quite high energies. I'm not frightened to go up into the 2.83 bars. I will be very nice to the patient afterwards though. And I will then kind of explain, you know, this is the reason why we're doing it and what the literature says. So we are getting some really good outcomes with actually elbow stuff. You, by all means, you know, you can use your taping, you can use your acupuncture. The reason why we're not saying to do so is that they're actually working on very similar systems in terms of the neurological cascade of events that occur. So we're not really, you know, it doesn't matter. You can go with and go without. But we're getting really good outcomes equally. I think realistically, more literature has been done on lateral epicondyle and medial. So there's a little bit more evidence out there for that. But outcomes-wise, if I was to pick, I'd say I get better outcomes with lateral epicondyle than I am with golfers. But I think realistically they're relatively equal within the clinic here.
Thanks.
Pleasure.
I'm laughing a little bit because thank you, Sida Jayabalan. He's saying excellent presentation. You have a non-complaining and non-fussy patient. Thanks.
Yeah, he's pretty
Thanks
good.
to Chris. Yeah. So
pretty good.
Very interesting. And a quick question from Simon Jones. What comms are you using?
Patient-reported outcome measures. So we are using just your standard questionnaires. For the shoulder, I'm using the SPADI questionnaires. For knee, I'm using Oxford knee scores, for knee OA particularly. For your patellar tendinopathies, I'm using Visa Ps. For your Achilles tendinopathy, I'm using Visa As. I actually adapted the Visa A slightly for plantar fasciopathy as well. So that, again, there's no evidence for that. It's just my little questionnaire that I put together. and it isn't verified by the literature, but it is something that we are using in the clinic. And for your elbows, I'm just using VAS at the moment, so I'm just using the pain scores at the minute for tennis elbow. There are questionnaires out there for that though. I do know them. I can get them. Where is it? Shoulder rehab. Right. You can for adhesive capsulitis. We're just using SPADI questionnaires. You can get the patient-rated elbow evaluation, which is you're looking at pain over 5 questions, and then you were looking at function over, I think, about 12 questions, and they are rated from 0 to 10 all the way through, and that is never to always, basically. So it's the elbow would be, when is it at its worst? So in the morning or in the evening, at rest, when lifting, when doing tasks or repeated tasks with the elbow movement, and how often do you have pain, never versus always. And then you've got specific activities then, like combing hair, eating with a fork or spoon, pulling a heavy object. So you're looking at the function. So there is a patient-rated elbow evaluation questionnaire, which can also be used. So yeah.
Okay, perfect, thanks. We have a question from Michelle from South Africa. Hi, Michelle, again. Have you had any experience with using shockwave on lateral epicondylitis when radial tunnel syndrome is present? So
I haven't. Yeah,
RTS is often masked by the symptoms, by LE symptoms, and they often occur together. Is there not any risk of over-inflaming the posterior interosseous nerve with shockwave therapy? How would you manage such a patient?
So I again, very fortunate that I can scan to confirm the diagnosis. So yeah, I agree that the presentation will be similar. But if you have any doubt with it, I highly doubt that you're going to do any harm. I mean, even if the patient hasn't got, or if the patient is getting radial tunnel syndrome, you treat it the same in terms of if you're suspecting a lateral epicondylopathy and you're doing 3 sessions and it just hasn't helped, that's maybe when you want to look at come back to your diagnosis and reinvestigate. I wouldn't be too concerned about that in terms of aggravating it. So don't panic about that, really. It's just really.
And the results are there anyway.
Yes. Yeah.
Okay. Thank you. Thank you. Question from ID. Could we see the before and after ultrasound images you mentioned on the 3 treatments of your clients, please?
So they won't be ultrasound images. They are images of the patient's functional range. We don't, like I said, we don't emphasize before and after for ultrasound images because sometimes we don't see a change in the actual density size, particularly for calcific densities, but we will see a change in function. So and reduced pain. So we don't really emphasize the before and afters for ultrasound, but we will emphasize before and afters with range of motion and movement. So they have been posted online, so I suppose there's no reason why I can't. May have to double check with the patient again, but yeah, as providing the patient's okay with it, then we should be absolutely fine.
Thank you. Thank you. I have a question. We don't have any more questions, but I have a question myself. Well, we hear lots of people suffering from back pain. Well,
yeah.
And I was wondering if you treat commonly, if you commonly treat patients with back pain with shockwave therapy, or do you do manual medicine, or?
So yeah, as a chiropractor, it kind of is our bread and butter, low back pain. So it's what the majority of our patient base is. Now, that doesn't mean that I haven't used shockwave therapy for it, and we do get really good results. But I use it as an adjunct. I don't use it as a standalone. Having said that, at the moment I am using it for one patient who isn't suitable for manipulation. So we are using it on him, and he is doing really well after 2 sessions. So it's basically working onto the trigger point of the erector musculature and then going into the glutes as well. So this patient is a particularly difficult patient. Got a lot of comorbidities, etc. But no contraindications to shockwave. So we're able to use shockwave into that low back, and has done very well after the first 2 sessions. Significant reduction in pain, feels a lot lighter, got better movement, and that's one of the key things with them. We've actually had a delegate on a course that came to us and was sitting down all day and was getting a little bit of low back pain, and we asked her to bend over, and she could just go past her knees really into it, just barely get there. She's feeling a little bit stiff, so we said, oh look, just come on, and we did a little bit of shockwave on her, and immediately afterwards then she had restoration of full range of motion and touching the floor. So you can get those immediate changes and some really good results with it. So as a nice adjunct, it works really well. But because I'm a chiropractor, I don't tend to use it as a standalone. But that's just because we've got the manipulation skill set that we use.
And if a patient and if your patient is calling you and saying, "Oh my God, I'm suffering too much," do you have any? Do you advise him some? Well, let's say, I don't know, some cream, or to have to get some relief, or do you just tell him, well, it's part of the treatment and this is the response that the body...
We want to induce an inflammatory reaction at the end of the day, so sometimes you can get exacerbations with it. However, we try to keep them off anti-inflammatories throughout the course of the care. We'll try, if they need to take anything for pain relief, then they can. But realistically, they do often get that amazing pain relief response immediately after the session. So there's no need to we don't really push that too much. But again, it does happen sometimes, and normally I'll get them in and re-investigate to see if there's anything going on with the tendon or in the plantar fascia or whatever, and then I'll scan it again just to make sure. But very rarely do we ever find anything like that.
Okay, thank you.
It's okay.
We don't have any additional question, and maybe to finish on upper limb areas, do you have any case to share about, some cervical pain?
Again, just the chiropractic element for it, I don't tend to use it on a great deal of neck pain because we've got our own skill set. The majority of it, the great ranges of motion changes really with your adhesive capsulitis patients and your supraspinatus patients. Like I said, I will try and share that image as long as I've got the patients go ahead. But we were really, I'll see if I can kind of demonstrate. The patient initially was getting down to that range, and then at the end she was up to there. Which is amazing. So, after 3 sessions with a frozen shoulder, which she's been having for 6 months, and after 3 weeks, she is now able to kind of put her bra on around the back again. So that was the greatest change that we've really received. And it's one of the best outcomes that we've had in clinic for adhesive capsulitis. It was a little bit gutted because she was so pleased with it after the 3 sessions, that she didn't feel as though she required the further 3. But I would have liked to have seen that through to the end for the 6 sessions to see how much further we could have got her. But obviously, because of financial implications play a role with the treatment, that she decided, look, I'm happy with where we're at. It's getting better as time goes on. I don't need any more, which is always a positive from a clinician's perspective. But the curiosity side of me got the better of me, and I really wanted to find out whether or not another 3 sessions would push it further. So I was a little bit disappointed we didn't get that opportunity, but for the patient, it's a great. They only had the 3 sessions and absolutely brilliant. So really happy.
Definitely. And linked to lower back pain, we have someone asking if a patient has screws and plates in the lower back area, is shockwave therapy contraindicated?
Yeah, so it depends on really the settings. I think that when you look at the depth of shockwave, if you're going up into really high energies and the level of depth that we're looking at to reach the spine, you've got at least 3 centimeters of musculature before we get anywhere near the spine. So it depends on why they've had the screws in place, really. You know, you can still go into the muscles and some soft tissue work and, you know, use the larger 36mm head. That should be absolutely fine because it's not going to reach those levels of penetration. It's just one of those where I'd say just be a little bit careful, but it should be okay.
Okay.
It depends, and also how long the screws have been in place.
Yeah.
It's a little bit of a clinical decision, that one. I wouldn't want to hang my hat on it because I don't know the full information. But yeah, you know, just take care. It depends how long the screws have been there, why they're there, and what your goal is with shockwave therapy. But there's ways around it. Like you can certainly use the larger 36mm head, and that should be absolutely fine.
Okay, perfect. I guess we're coming to the end of the webinar. Thank you, Dan, as always. No. You're the best.
Pleasure, absolute pleasure.
It was a great presentation. We have nice comments from participants. Thank you all for joining today. Thank you, Chris, who's saying see you next week. Last question from Michelle. Have you any experience with FDP and FDS injuries in the fingers using 15mm head or silicone head?
On what, sorry?
On FDP and FDS injuries in the fingers. FDP and FDS.
Flexor digitorum profundus and superficialis, right. Yeah, not specifically, no. Realistically, for the fingers, we're using pulleys. So like trigger fingers works really well for pulleys and trigger fingers and dupentrons. I haven't had any, I'm afraid, Michelle, sorry, specifically to FDP and FDS. However, again, if we need to, I can potentially look at some case studies if there are any reported in the literature.
She's saying thanks, great thanks. And no tendinopathies in climbers?
Yeah, no, that works really well. Yeah, because they are going to be gripping through. So yeah, absolutely, that works really, really well. Again, very similar to the kind of the dupentron settings, 8 to 12 hertz. Try to just mix through 2,000 impulses or 1,000 impulses, whatever the patient can tolerate. It can tolerate and with the pressures, but 2,000 impulses, just making sure you're running through into that pathology will work really well.
Perfect. I think it was the last question.
Superb.
Thank you, Dan.
No,
thank
pleasure.
You all
thank you
for participating. Thank you, Dan. Yeah. Thank you for your nice patient, Chris, for joining. And we will let you know about the next webinars in the coming weeks. Well, it's summertime now, and it's also vacation time for some of you. So we will probably have another session, maybe in July, or maybe in end of August, or depending on the schedule. Thank you all for joining. You can follow Dan on his Facebook page, on Instagram as well. Please do so. Please do not hesitate to send comments and share some suggestions. We'll be happy. You can also send me a nice email or your questions as well by email, and we'll be answering them in the coming days. So that was for this practical session. Thank you again all, and we'll see you next time online. You can consult the website for another session, but we'll keep you informed by emailing. Thank you, and see you next time.
Thanks, guys.
Thank you. Bye-bye. Bye-bye.